So I'm going to spend a bit of time talking about Olivia, a tool that we have recently developed. If you are interested, please email me after the talk, my first name Majid at computerscience.ucla.edu, and I'll send you more technical and in-depth version of this tool, along with a number of machine learning analytics prediction on top of it. But for today, I plan to just provide a high-level idea. Olivia was inspired by the following ideas. In general, but more recently related to COVID-19, we hear and see news headlines. So how would we verify them is always a question, both for technical people like all of us, for people in epidemiology or what have you, or for average people that may not actually have a scientific background. A. B, if I'm interested or if someone interested in their local area and they are just curious about some information and they want to verify it, how would they do that? Sometimes it's hard to wait for the news to come. If I want to hear about COVID-19 in my neighborhood, is there a way to achieve that? So Olivia was designed and developed as a methodology to enable everybody, not just scientists, to gather some information and do some analysis and finding related to, in this case, COVID-19, but it's being extended to other disease conditions such as heart failure, diabetes, etc. So we have a big issue and we are really concerned about information and headline that may be incorrect. And we see that every day. I'm sure you have always observed that. For example, you may see headlines that there was a shark attack, but you probably will never see a headline that there was an elephant attack, although the chance of dying from an elephant is about 50 times higher than dying from a shark. So it's the news media that creates some of this. Let me give you an example. So I'm going to start with a few examples of what correlation means, what headlines make sense or doesn't make sense, and then we will use the same concept in defining and using Olivia. I will also provide a live demo of Olivia at the end of my talk for 2-3 minutes. So if you look at the statements that I have on screen, this is a study that was done, or a large number of studies that was done to see how a child becomes smart. And the metric that has been used is their SAT and ACT score of these children when they are toward the end of their high school. So the question was, are any of the factors that I have listed on my screen correlated to whether a child is going to do well or not? Whatever well means, and in this case means ACT, SAT score. I've highlighted some of them. So the child had a low birth weight. So average maybe 7.5 pounds. A child has a 3-pound birth weight or 5-pound birth weight. Would that be correlated in any way to how well they're gonna do in school? Second, a child is adopted. And there are a bunch of others. The parents are highly educated. Family is intact, meaning parents are together with the kid. The family have recently moved to a better neighborhood, from maybe a tough neighborhood to a better one. Sorry for misspelling. Mother didn't work and stay with the kid for the first 6-5 years. The last one, the parents read to the kid every day or almost every day, maybe 5-6 times a day. So think of it for yourself, maybe your experience with people you know, and see which of these you think is gonna be correlated to how well a kid is gonna do. And I see these bullets in the news every day. One that I see a lot on my commute, pre-COVID commute to work, is, in fact, there are these public announcements that says you should read to your child very fast bullet, very last bullet, and the study shows the kid is gonna do much better. So I'll just spend, a few seconds thinking about this, and if you had to pick one or two that actually correlates, which one would it be? About the yellow ones that I have highlighted, which one do you think is actually going to correlate or not? So if I tell anybody any of these bullet forms, they probably all believe most of it or some of it, depending on their experience. It turns out that anything on the left is actually correlated. For example, the child had a low birth weight. It's not causal reason, but it's correlated. And everything on the right is not correlated. So if the family has moved to a better neighborhood, that doesn't mean the child is gonna do better in their ACT, SAT score. If the child attended the Head Start, meaning they kind of started school earlier at the age of 4 or 5, that's obviously encouraged. But those who encourage you to do that are probably financially incentivized to do that. And the biggest one that we hear, and I hear all the time, is the parents reading to the kid. It turns out that's not correlated to what the kid does. In terms of ACT, SAT score, maybe it's correlated to other things. So our job as scientists, I think, is, of course, for ourselves to always try to look at correlation, causality, and just not believe the headlines that we see, because somebody's incentivized to make these headlines. And I have hundreds of examples in the course that I teach in data science that I use about, booster seats for kids, etc. And a lot of them are because people are incentivized to say things like that. So really our goal is to ask a question, obtain data, and Olivia will try to do some of that, understanding the data, correlating the data, relating the data, and through that, hopefully understanding the world and reporting the data. When I was in San Francisco, I saw, this is 4 or 5 years ago, 2014 actually, I see that they had these scores on food safety. So we went to this restaurant and it says the score for this restaurant is 96. And if you look at the guideline below, it says any grade greater than 90, that's good. 86 to 90, it's all right. Less than 70 is not so good. So we immediately see this and we believe it. So my inclination is to go and eat in this restaurant. But if we dig further into this data, I may change my mind on that. For example, we went to the environmental health department of public health in San Francisco. And it says greater than 90. And one of the things is it may have high risk violations. The food is not clean and all that. Whereas just looking at the grade 90, I wouldn't believe that. So is that grade inflation? Should I believe grade of greater than 90 without seeing through that? And now I have second thought after I'm seeing these guidelines. So unfortunately, these are usually not provided. Maybe there are incentives. Maybe the incentive is for people to go out more to restaurants and not to report everything. You are all also familiar with grade inflation in colleges. We hear all about that. faculty giving better grades to the students so they can supposedly get better jobs, and so they are incentivized for that. Other examples that we see, smoking and cancer. Today, obviously, we all believe, and there are a lot of studies, that smoking causes cancer. But if you look at, this wasn't so obvious 20, 30 years ago. In fact, you know, most people believe this is not true. Incentivized by companies who sell cigarette and tobacco. But even there, if you plot from 1950 to 2010, males, as their smoking rate decreased, the lung cancer rate decreased. But for women, for female, as the smoking rate increases, the lung cancer goes lower. So does this data suggest that for women to decrease their lung cancer rates, they should smoke more? Maybe. Of course, that's comical to us today, but just purely looking at this data and replace smoking with whatever else, because we know so much about smoking, we may draw that conclusion that indeed, for example, eating gluten-free, replace smoking with gluten-free. This slide may suggest that to decrease cancer, you should eat more gluten-free. And of course, the industry has incentive to make you believe that. So again, we need to dig down into that. Maybe for us scientists, it's easier, but for an average person, it's very difficult to dig down. So we should, I think, as a community, provide tools to facilitate this digging down and focusing on the data for average people. By the way, on smoking and cancer, of course, it's not true about female. Reasons might be, I understand this from my colleagues who work in this area, that on oncology, that lung cancer is not all the same, only some of them are associated with smoking. So there are many reasons which make you question the data you see last time. This is, to me, this is something I use all the time, and you have seen maybe slides like this. If you look at the data here and the curve, it seems that marriages in Kentucky and fishing boats death are highly correlated. Of course, this doesn't make sense. This is not true. It just happens that the data look the same. So we got to see what the cause of these are. And we need to dig down and focus in some areas. And just because the two curves look similar, that's not the end of the story. But unfortunately, these are the things you see in news media and in scientific publication. You may see headlines like this. Of course, not something as obvious as marriage and drowning, you won't see, because people just, you know, will highly question that. But things that are not so obvious, you see that in the media and in scientific articles a lot. Okay, so let's get down and talk about Olivia, which is motivated by all the discussion that I had earlier on. Some of the things related to COVID-19 that I've seen headlines is 52 workers who worked or voted in Wisconsin election have COVID-19. So this may suggest that you should not go and vote or work in these voting precincts. That may be the suggestion that the headline is trying to convey. But if you dig down in the article, it's not clear how these guys got COVID-19. Was it related to election? That's not at all clear, but that's not gonna be in the headline news, because it's not as attractive if they put kind of the truth or the detail in it. Something that I saw today is, in this morning, was Florida and Texas governors blamed the spike in cases of COVID to increase testing. They are saying because we test more, that's why you see more cases. It's not because the states are open and people go out there and they don't wear masks and no social distancing and all that. So how do you verify that? And if you look at different news media, they're gonna twist this in multiple ways. So how can we verify that? How can we provide tools for people to verify it on their own? That's the question. So the overall system architecture for Olivia is we get many data, we get census data, we get CDC data on various obesity rate, diabetes rate, you have it, hospitalization, death rate, COVID positive from multiple sources, including Johns Hopkins data, who in turn get it from multiple other sources. We get a number of data from Google and Apple, for example, mobility, because we hear mobility is quite important. That goes through a database that's hosted on AWS. We have an analytic engine, and the user can interact and do various charting and draw conclusions. This is sort of the overall architecture. Other things that we have included in this system are, if you are familiar, happen to know about our system called Wanda, which was designed for heart failure, where we deploy a large number of sensors like pulse oximeter, heart monitor, blood glucose monitors. We ask daily questionnaires, and all of that data comes back to our engine. Even though Wanda has been acquired and now it's a commercial entity running from UK, but the number of data items we are getting through that is quite small today. So gathering data through sensing, unless it's purely from the phone, is quite limited, and not much you can do with it in the larger scale, in the millions or hundreds of millions. Another tool that we have is for oncology patient, cancer patient. It's what we call the smart home in a box, where we give each individual a smartwatch that we program. We also provide a number of beacons. So we know that if a patient is sitting on their couch all the time, how many times they go to the refrigerator, how many times they go to the bathroom, how much time they spend in the bedroom. Through this proximity sensor, we know all of that. This has been deployed to 500 homes in Los Angeles. And the whole cost and the idea of a smart home in a box is you just send the box to the patient. The box costs about $100, and you don't need anybody to go and install it. They can do all of this on their own. So again, we are gathering data, but it's limited. It's 500 or so. So it's really hard to scale these things up unless, larger companies take over. So Olivia Interface, if you go, and I'll show you how to do it on your own. If you push on regional-based COVID, it gives you the tool. You can do regional comparison. I'll tell you what that is. Any finding that's done by us and others, you can go under interesting finding. Or if you find out some interesting result that you want to share, you can submit that, and we put it in interesting finding for everybody to see. I'm going to go through this slide later when I run things live. Well, actually, this slide, I'll talk about it. So if you simply forget about the colors, if you look at the x-axis here is diversity of Black race ratio, and the y-axis is the death count that's normalized, meaning per capita. So if you forget about the colors, it seems there are some people here that are not, highly dominant in Black race, but they have, large COVID. But if you also color, the color here is how many people use the public transit. So it gives you these red and yellow. These are the people who have high Black race ratio and they use public transportation. And you see now there is a high correlation of them to the number of deaths. So you can, of course, it's not our job as data scientists to kind of make sense of this. It's for policymakers and others to kind of look at this data and say, these are the reasons, or how should we change the policy to reduce the number of cases in the future. This one I'll go through by running the tool. We also can do regional comparison in Olivia. So we give it group 1. This week, there were a number of states reported in CNN and Fox and other places where the number of COVID cases did not increase by much. This is group 1 shown in green. Group 2 are states where the number of COVID cases actually increased. Arizona and Florida, as you can guess, are 2 of them. So we can give these 2 groupings to Olivia, and we can tell Olivia, run through all possibilities, all parameters, obesity, mobility to work, or shelter in place, and all that. And tell me the one or several parameters that distinguishes these 2 groups. So once we run that, it turns out the only, I haven't labeled the x-axis, but the only parameter that distinguishes these 2 groups are mobility.
We seem to lose him. Did you share screen with us?
I will do that right now. You should see it in just 1 second. And this will take only 1 minute to run it. Can you see my screen?
Yes.
Okay, so if you go to x-axis, you can set so many different parameters. I'm gonna pick Native American diversity as x-axis. As y-axis, what I want to see is maybe death rate per capita, per 100,000 people. As the color parameter, maybe that's okay. I just use the number of ICU beds and cumulative. Region labels, do I actually want to see the name? Yes. And resolution, I want to look at this at the state level, and I do a plot. So it's going to take hopefully just a few seconds to run. Okay, so x-axis is Native American, y-axis is the death, etc. So the date is 1/26/22, back in January. So obviously there were not too many cases. I'm gonna push this, and it's gonna show you the cases from January all the way to today. So you're gonna see more states as more death was reported. And you can stop it and look at any date, April, March, etc. So you see all the states. This is Arizona, this is New Jersey, New York. So the conclusion is the Native American population at a state, at any state, is not correlated to COVID date. So you may see that in the news that, you know, Native Americans are actually doing quite well because there is no correlation. But you, as an average user or as a scientist, say that doesn't make sense. Let me do further analysis. So instead of a state, you say, I want to go to the county level. Because if I go to the state level, since the number of Native American is relatively small, I may not see it. And for a state, let me just look at Arizona, or you can say Arizona and New Mexico. Let me just do Arizona and run the same thing again. And I'm gonna, the one you see here, Maricopa, that's where Phoenix is. So there was no death for a while in Arizona. Today, Arizona is one of the worst. Let it run all the way to today. So look at this. The counties, Navajo County, Apache County, that have a very large number of Native American, 40%, 50%, 70%. They have a huge death rate, sometimes twice or 3 times, and other counties that don't have enough Native American. So now your conclusion is within a local community, in fact, where there is a large Native American population, the death rate is high. So as a data scientist, you provide this. Or an average person who lives in Arizona or is interested in Native American can run this and can run it for other states like New Mexico or Alaska. They all have a large population of Native American. And then somebody else will come up with the right policy and right procedure for this. I'll stop here. If anybody is interested, please email me at majid@csucla.edu. We have very detailed technical papers along with prediction and all that. I'll be happy to provide it.